food, drugs, or ideas, what you consume influences who you become. On the Mind and Matter podcast, we learn together from the best scientists and thinkers alive today about how your mind-body reacts to what you feed it. Before starting Mind and Matter, I spent 10 years in academia doing scientific research. I got a PhD in neuroscience where I focused on neuroendocrinology and the neurobiology of behavior, and before that, I specialized in molecular, developmental, and evolutionary genetics. I use my scientific background to help parse and translate the information that guests share on the podcast. In addition to the podcast, I write long-form written content inspired by the show where I integrate what I've learned across episodes. I also have a free weekly newsletter where I provide you with upcoming guests, share links, and provide commentary on scientific studies and research that I'm reading, and more. Visit mindandmatter.substack.com to find all of my content. You are about to listen to the full episode, but there will be 1 to 2 short ads immediately following this before the conversation. If you would like to hear ad-free episodes and get early access before they release more widely, become a paid subscriber at the Mind and Matter Substack at mindandmatter.substack.com. Becoming a paid subscriber is a way to directly support my efforts, allowing me to make more episodes and higher quality episodes, and also helping to free up my time so that I can spend more of it on doing research and synthesizing results from the podcast and from the literature so that I can do more things like writing on the Substack, putting more content into the newsletter, and getting these things out more frequently. So if you want to support the show and get ad-free episodes, go to mindandmatter.substack.com. Hey everyone, I want to take just a minute to tell you about a really cool health monitoring device I've been using called Lumen. It's a handheld, pocket-sized device with a sleek design. The Lumen device measures CO2 levels in your breath, which allows their technology to determine the extent to which your body is burning fats versus carbohydrates. Lumen helps improve your metabolic flexibility, your body's efficiency in shifting between using fats and carbs for energy. I use this device in the morning or before bed or after meals or after workouts to track my metabolism. With just a couple weeks of use, I learned a lot about which foods were causing my body to burn mostly fat, mostly carbs, or both, as well as how long I needed to fast and how hard I needed to exercise to promote fat burning. Being able to track whether your body is burning fat versus carbs will help you figure out how your body responds to your lifestyle and whether or not your weight loss and fitness strategies are actually working. Lumen is great for anyone looking to optimize their health for either weight loss or athletic performance. Their easy-to-use app allows you to track your results together with what you're eating and how you're exercising, and it syncs with other devices like the Apple Watch. Click the link in the episode description to learn more and use the code MINDMATTER, MINDMATTER, to get 10% off your Lumen device today. That's on top of the site-wide sale they are currently running, and the Lumen device is eligible to be paid for with FSA and HSA health accounts. Check out the link in the episode description for more info. Thank you very much for joining me.
Oh, it's a pleasure. Thank you for having me on the show.
Do you want to just start off by briefly telling everyone a little bit about who you are and what your background is?
Yeah, I'm a preventive cardiologist. I'm a professor of medicine at the UCLA School of Medicine here in Los Angeles, California, and I'm the program director for cardiology in Harbor UCLA in Torrance, California.
Okay, so you are a heart doctor. You know something about the heart.
That's been what I've been doing for a while now.
So before we get to the study that you just did, you're part of this study looking at the ketogenic diet, following people for a year, and looking at things related to heart health. We're going to get to that, but I want to give some people some background and some basic concepts to set up this study. Starting with cholesterol. When people talk about their cholesterol levels and getting blood work done and thinking about heart health, they're typically going to talk about LDL, VLDL, and HDL. What are these different things, and what is cardiology typically, what is the orthodox view in cardiology for how we think about these things in relation to heart health?
Yeah, I mean, so, typically LDL cholesterol is our most modifiable risk factor. So once you have established heart disease or plaque in the arteries, that's our target for treatment. Not everybody with high cholesterol gets heart disease, and some people with low cholesterol get heart disease. But once we know you have heart disease, we want to lower that value because it's too high for you. It's too high for that person if they have plaque in the artery and their LDL is not ideal.
I see. So having high LDL does not necessarily mean you're going to get heart disease, but if you already have plaque buildup or you're prone to heart disease, then your LDL can be too high, basically.
Exactly. So it's more of a treatment target than it is a risk factor.
Mm-hmm. And so when we talk about the things that really cause heart disease, when we talk about atherosclerosis and plaques in our blood vessels, where are those plaques coming from? Do we have a good sense of that? The view that you hear most often is, oh, that's cholesterol. The cholesterol builds up and gums up your arteries. Is that what's actually happening?
Well, there's a lot of factors though, because you can have a genetic predisposition, right? If your mom or dad have heart disease, you're much more likely to be affected by heart disease. Diabetes can cause plaque to build up, high blood pressure. So cholesterol is just one factor of many, but it is the primary component of the plaque itself. That's why we try to treat. If you have heart disease, we want to get rid of that plaque, and that's why we treat the LDL.
Mhm. So, but is the LDL, is it forming the plaque? Is it what's causing that, or is it getting there to help clean it up or something like that? Because I've heard people say both things.
Um, the so the plaque is made up of cholesterol, part of it. Yeah, there's definitely a component that's cholesterol. But again, people have very high cholesterol. Some of them never develop plaque in their arteries at all. So it's not always a one-to-one relationship.
Okay. And so what would be the difference between LDL and VLDL?
Um, so VLDL is more fats. That's the triglycerides. So that's a different component. The first thing the body makes is VLDL, or very low density lipoprotein. That gets converted to LDL. LDL is more of the cholesterol particle. VLDL is more of the fat particle.
Mhm. And then we've got HDL. How is that different?
HDL is the good cholesterol. So that's the high density lipoprotein that takes the cholesterol from the periphery and brings it back to the liver for disposal. So it's kind of the reverse cholesterol transport, we call it. That's the good stuff.
Okay. Okay. And then the other thing I want to cover off on is ApoB. So what is ApoB and how does that tie into this?
Um, so ApoB is a more accurate measure of all of the bad particles. So that includes LDL, VLDL, and other particles that are missed in that measurement. So
Mhm.
ApoB is another more accurate way of measuring all of the bad particles in the bloodstream beyond just LDL.
Yeah. And so I would imagine LDL and ApoB correlate with cardiovascular disease risk. People who get cardiovascular disease tend to have higher levels of both of these things. That's generally true?
Yes, but the relationship is very weak,
Mm,
and we don't usually, again, think very strongly that's our primary risk factor. So it's not a good marker of risk.
mhm.
It's just not it's not a strong marker. It's a very big misconception among a lot of people.
I see. I see. Okay. And then I want to talk about triglycerides a little bit. So, for example, your liver can make triglycerides, and we can talk about what that is. A common marker that I hear people refer to in terms of being one way to gauge metabolic health is the triglyceride to HDL ratio. So, what is that, and what does it actually tell us about overall metabolic health?
So yeah, triglycerides are bad particles. They're inflammatory. They're the fats. So it's kind of like the bad particles, the fat particles divided by the good particles, the HDL. So if your HDL, your good cholesterol is high, that's good for metabolic health. People who exercise a lot have good health overall, have good HDL. And triglycerides are the fats and the inflammatory markers. And if those are high and your HDL is low, your ratio is very high. So that's kind of a bad over good relationship. And the more the bad is, or the lower the good is, the worse those numbers become.
I see. So if your triglycerides are, if you're relatively healthy, you're metabolically healthy and fit, your triglycerides will tend to be low, your HDL will tend to be higher. The triglyceride HDL ratio will be low, and we tend to think of that as a good thing. And then if you're unhealthy, we see the opposite relationship. That number goes up. Now, traditionally, I would assume, based on sort of the traditional cardiology beliefs that are out there that are around how cardiovascular disease starts. If someone is healthy, then you would expect their triglyceride HDL to be low, and you would also expect their LDL to be low. But I think what you're going to tell us is there's actually cases where people are metabolically healthy, even though their LDL is quite high.
Yes.
And so so sort of in the classic cardiology literature, looking at atherosclerosis, the relationship between these cholesterol and triglyceride markers and heart disease, when people study these associations and they find that there's a statistically significant, but you said weak link, say, between or weak association between LDL, ApoB, and cardiovascular disease, is that literature mostly looking at people in general? Is it mostly looking at people that already have issues like high blood pressure and plaque buildup, or is it looking at healthy people and sorting these different groups out from each other?
So yeah, I mean, whenever you look at a population of people, it's not everybody conforms to that. So we talk about population-based medicine, where we kind of look at risk factors in general, or we look at individuals, and it doesn't always correlate. For example, some people with diabetes don't get heart disease,
Mm-hmm.
but a lot do. So we think diabetes is a risk factor, but in a given individual, they can have raging diabetes and their coronaries are completely clear. So we always have to look beyond the risk factors to the individual, and that's why we do the CT scans and the plaque assessment to see what's going on in the arteries, not just what should be going on in the arteries.
Mm-hmm. So based on what you've told me so far, it sounds like, as a cardiologist, if someone was old enough, whatever that means, in their middle age, and they want to get an assessment of their heart and cardiovascular health, it sounds like you can't solely rely on biomarkers like LDL and ApoB. What would be like the number one or top couple things you would do to assess someone, say, who's middle aged in terms of what their plaque buildup looks like or what their overall cardiovascular disease risk actually is?
Yeah, so I recommend, and so does the American Heart Association and the American College of Cardiology, to do what's called a calcium scan, to do a simple scan of the heart. It's done with a CT scanner. It's very, very easy to do. It just takes a couple minutes, and it looks for plaque buildup in the arteries. And if you're one of those people that have a lot of plaque, regardless of your LDL, we've got to get on top of that. And if you're somebody who has a high LDL and a lot of bad cholesterol and your coronaries are completely clear, we say you don't need to treat it for the next 5 years. Those are the guidelines.
Hmm. So that's interesting. So someone in my family who's almost approaching 60 recently came back and they were talking to me, and their doctor said, your LDL is too high. We need to get you on a statin right now. And I asked her, what did your calcium scan look like? What do your arteries look like? And she said, I've never gotten one. And I said, never? Not since you were 40? Does that surprise you? And would you, as a cardiologist, would you put someone on a statin not having looked at that type of scan?
I mean, unfortunately, there's still a lot of doctors who just go with the numbers and say, "Oh, your LDL is high. Let's put you on a cholesterol medicine," and that's never been the guidelines, actually. But that's just a not natural reflex. Is that your cholesterol is high? Let's just lower it. But again, if you have no plaque, you're not treating you're treating a number. You're not treating your body,
Hmm.
and you're taking a drug that you don't need. So I'm not surprised, but it's unfortunate that we haven't moved beyond that.
Hmm. And so give us a very quick rundown how statins actually work. They're used to lower LDL, but what are they actually doing, and how effective are they really?
Yeah, so statins lower LDL by blocking production of cholesterol in your liver. So that's where we make all of our cholesterol is in our liver. We absorb about 15% of our cholesterol in our diet, and about 85% is made in the liver. So the vast, vast majority um, would be in the liver. And statins block that absorption. So that's really how they work. And they're very effective. They lower cholesterol by about 30 to 50%. So they cut that LDL cholesterol in half in many patients. And we think that's a good thing if they have plaque and we're trying to treat the plaque, because the minute the cholesterol drops by 50%, the liver is like saying, "Hey, I want more cholesterol," and it starts to look for cholesterol from the bloodstream, and it pulls it out of the bloodstream. So that's where the reverse cholesterol transport comes in. So the response to a statin is to lower LDL cholesterol by about half.
Hmm.
If you use a high intensity statin, they also lower inflammation and they also reverse plaque in the arteries. We know that we've seen that happen in multiple trials now, where the arteries look better after 1 to 2 years of being on a statin. They have less plaque in them.
Hmm. So it sounds like your basic approach as a cardiologist is if someone has plaque buildup, as shown by one of these calcium scans, and their LDL is high, then you will likely put them on a statin to lower those LDL numbers and hopefully reverse some of that plaque buildup. But if their calcium scan comes back clear and there's no plaque buildup, even though their LDL is quote unquote high, you probably would not put them on a statin in that case.
Yes, that's correct.
And so how else can we change LDL levels in the body from a dietary perspective? My understanding is that, for example, polyunsaturated fatty acids will tend to be associated. If you boost the intake of those, that will tend to lower LDL. Is that true? And is that or are there other dietary ways to change LDL levels?
There are dietary ways, but the problem with diet is that it only controls about 15% of the cholesterol on average. So even if you went from a relatively poor diet to an exceptional diet, your LDL is only going down by about 15%.
Hmm. And so, related to that, what about dietary cholesterol? A very, very widespread belief out there is that if you start eating more cholesterol or foods with high cholesterol levels, that will significantly boost your blood cholesterol levels. What's the relationship between dietary cholesterol intake and the actual serum cholesterol that would be measured inside of a person's blood?
Yeah, it's a weak relationship. There is definitely some increase, but it's pretty very modest. Since dietary cholesterol only accounts for 15% of your total cholesterol, dietary cholesterol accounts for a very small percentage. And triglycerides, fats, carbohydrates that you eat can convert into fats and LDL cholesterol ultimately. So it's the carbohydrates are bad and bad players, and cholesterol itself may not be the primary problem when we talk about dietary intake of nutrients and what that converts it to.
Hmm. Hmm. And so, starting to think ahead to this study here. So, when we think about the carbohydrate and the fat content of diet, obviously both can be high or low. You could have a high carb diet that's low fat, or vice versa, or it could be high in both. When you think about the fat and the carbohydrate content of diet, how does that start to play into things like cholesterol levels, and how does something like the ketogenic diet look different from a cholesterol perspective from a standard American diet?
So you're doing so ketogenic versus standard. I'm sorry, is that the
Yeah, just
okay?
how does the macro, let's just start here. How does the macronutrient composition with respect to fat and carbohydrates tend to relate to things like LDL and blood cholesterol levels?
Yeah, so I mean, in general, your cholesterol intake, your fat intake, carbohydrate intake can all slightly affect your blood cholesterol levels. There's not a very strong relationship in most people. So if you eat a lot of lean meats, you might not have any increase in your cholesterol. If you eat a lot of carbohydrates, if you're a vegan and you eat a lot of French fries, your cholesterol is going to go up significantly.
Mhm.
So there's no one diet that's protective towards cholesterol. It's just a different response in different people. It's based on volume and your underlying metabolic health. So there's a lot of factors that go into a response from any given diet. Generally, we think of a lean, healthy diet being something that's higher in fruits and vegetables and lower in processed foods. But really, a lot of it has to do with the volume of food and the carbohydrate content of food.
Mhm. Mhm. And so, what is a ketogenic diet, and what does that look like?
Yeah, so a ketogenic diet is one in which the body is basically starved of carbohydrates, so it becomes ketotic. It goes into a process of uh, developing energy through what's called ketone bodies to deliver energy to the cells because there's not a lot of carbohydrates floating around. Carbohydrates are usually our primary fuel. And when you have a keto diet and you have no carbs, or very low carbs, you have to find an alternative energy source for the body.
I see. So in essence, when someone's in ketosis from a ketogenic diet or from fasting, they are using fats as opposed to carbohydrates for energy. So instead of using glucose to generate the energy currents of the cells, they're using these things called ketone bodies.
Yes. And if you get too many of them, you get ketosis. You get measurable ketone bodies in the urine and in the blood.
And so, what are the ketogenic diet has become more common in recent history. People are talking about it more. What are some of the things that the ketogenic diet is being used for or studied for in terms of therapeutic and the health side of this? What types of people are looking at the ketogenic diet?
Well, I mean, so yeah, it's definitely associated with weight loss. It's actually a fairly significant way to lose weight because the low carbs means low calories, and if you're taking in less calories, you're going to lose weight. Your body also shifts to this burning of fats, which is also good for weight loss. So it's a very dramatic way for some people to lose weight in the short run. But we've seen it for patients with diabetes, to help their blood sugar control because carbohydrates become sugar in the bloodstream. So that's good for patients with diabetes, both type 1 and type 2 diabetes. And it's also been used for things like seizures. There's the Epilepsy Society and Epilepsy Foundation have advocated as an effective way to manage epilepsy. And there's a host of other purported benefits, and different people have used it for gastrointestinal disorders, for problems of their gut, and a host of other uses that have been purported. I'm not an expert on the keto diet, to be honest. I did a research study on it, but I know it's used for a fair number of different people across different aspects of healthcare.
Yeah, yeah. So this ketogenic diet, it's being looked at and used in for a variety of purposes now, ranging from something very, let's just call it physical, like weight loss, shedding body fat, but also things like mental health and even things like epilepsy. That's the sort of classic first thing I think it was known for. So before we get to your study, the one that you just published, I want to cover off on a couple more things. So there's something called the lean mass hyperresponder phenotype. And this is going to tie into how being in ketosis relates to things like LDL levels. What is this phenotype and what do we actually know about it to set up the study?
Um, so um, the lean mass hyperresponders is a group of people who start out without a lot of body fat. So they're healthy, they're lean, and for some of them, when you go on the keto diet, for whatever reasons that they might choose to do that, their body makes more LDL cholesterol. So they're called hyperresponders, where their LDL cholesterol goes up dramatically. It can go up from normal values, 70, 80 milligrams per deciliter, up into the high hundreds. I've heard of people going up to 1,000 LDL cholesterol in response to this diet. So their metabolism shifts. They're probably using LDL to try to deliver energy because they don't have a lot of fats, they don't have a lot of triglycerides, and their LDL particles go up dramatically, and they have this hyper response to cholesterol.
Mhm. Okay, so these are lean, metabolically healthy people. So if you were to look at their blood work, they would have, say, a low triglyceride HDL ratio. So they've got enough HDL. Their triglycerides are low. That's good, but they have very high LDL numbers. Even though they have very high LDL numbers on this high fat, low carb diet, even though they are lean, metabolically healthy, and don't appear to be predisposed to, say, heart issues or something like that.
Right, correct.
Okay, so now the question here naturally is if they look otherwise healthy, but they've got very high LDL levels, which are classically known as your bad cholesterol, the question is, are they actually at risk? Is this high LDL level actually bad? So what's been the thinking there going into your study, and what are the sort of different ways that cardiologists and people in these fields would think about this in terms of whether or not it's actually going to turn out to be good or bad for these lean people?
Yeah, and I think just out of the box, people reflex says, "Oh, if your LDL goes that high, that's terrible. We have to do something about it. You're at high risk because your LDL cholesterol is so high." And people have said you have to stop the diet, you have to change your lifestyle, you have to get on a statin. There are other people who believe that because it's just a physiological response to energy transfer, and these people are otherwise metabolically very healthy, that it would not be a significant problem, and therefore would be okay, if you will, to go through to have that high in LDL cholesterol as long as you're otherwise healthy.
Mhm. So what I'm hearing is, so if the first viewpoint is correct and having those high LDL levels is bad, even though these people are lean and metabolically healthy and otherwise look good, the prediction would be that having those sky high LDL levels for an extended period of time is going to cause more plaque buildup. So we should see these people build up more and more arterial plaque given that their LDL is that high. The alternative viewpoint, or and a different way of looking at this, is that these people are lean and metabolically healthy. Their body is using more fat for energy as opposed to carbohydrate. And so the high LDL is not a reflection of something bad happening and plaque's going to build up. It's a reflection of their body moving around fat to use for energy, basically.
Correct.
Okay. And so set up this study for us a little bit. I think we've essentially covered off on some of the motivation here. What did you do in terms of the basic setup and methods of this study?
Yeah, so we were very careful in our patient selection. We actually screened a lot of people to find these people who were one in ketosis from the ketogenic diet. So we had to prove that they were effectively in the ketosis state, where ketone body's measurable in their blood. Two, they had to have an LDL well above normal. And three, they had to have a normal LDL prior to starting the keto diet. So we excluded patients genetically as well who could have had what we call heterozygous FH, or high cholesterol from a genetic predisposition. So these were patients who had normal cholesterol. They had no issues with LDL cholesterol. It was very normal. And then they went on this diet and it went up dramatically. And those are the people who we enrolled in the trial.
I see. So you specifically wanted to look at people that did not have some genetic predisposition to very high LDL cholesterol. You wanted their LDL to be high because it was induced by being in a ketogenic diet state, by being in ketosis. They were lean and metabolically healthy. So these are not obese people. They've got good, meaning lower triglyceride numbers. They've got higher HDL numbers. And they've got various other markers indicating that they are not in chronic inflammation, that they're metabolically healthy. So these are your lean mass, metabolically healthy people, and they've got very high LDL because they're on a ketogenic diet specifically.
Exactly. Exactly.
Okay. And how many people did you look at, and how did they reflect the general population in terms of, say, their demographic features or anything else that one might care about when we start to think about whether these results will generalize?
Yeah, so we enrolled 100 of these participants, scanned them at baseline using the CT angiogram. So that's an advanced metric of plaque assessment. We looked at quantitative plaque in the coronary arteries, how much plaque is present, soft plaque, hard plaque, all the different plaque components. We followed them for a year. They had to stay in ketosis. We monitored them. They had to be remaining on the keto diet. And at the end of 1 year, we scanned them again to look at the change in plaque over the course of a 1 year time point.
Mm-hmm, mm-hmm. And so did you remind me, how did you guys confirm that they were in ketosis the entire time? And what kind of tracking did you do for their diet in terms of knowing exactly what they were eating and what the fat content was?
Yeah, so they had to do regular finger sticks to prove that they were in ketosis. We also measured their LDL and advanced lipids at baseline and at follow-up. So we had a home monitoring during the year, and then we had formal testing of both ketones and LDL at baseline and follow-up in the trial.
Mm-hmm, mm-hmm. So these people are they're bona fide ketosis. You're checking that. You're checking ketone body levels, and you're measuring these lipids and other things. Before we get into the results, one more question I have is there's not just one way to be in ketosis, right? So all of these people could be having very, very little to no carbohydrate intake, but their fat intake could still, while it's high across all of them, it could still differ a lot from person to person. Some might be having more saturated fats, some a lot of polyunsaturated fats, and everything in between. Did you look at the fatty acid composition of their diet and how that varied at all?
We have not. We have not. We have the blood work. We haven't delved a lot into how they got to ketosis, and there are a variety of ways and a variety of diets. So, and because it's only 100 people, we're a little bit nervous about trying to subset it too many times because it's not a huge cohort.
Mm-hmm,
So,
mm-hmm.
you don't want to do too many what we call subgroup analyses when you have a smaller cohort that you're playing with.
Okay, so maybe a question for another day or something to keep in mind for people interested in this stuff is, something I'm very interested in is, what happens if you have a high saturated fat ketogenic diet versus a high mono or poly unsaturated fat ketogenic diet. We don't know the answer to that yet, and you guys weren't really in a good position to look at that specifically here, but you know that these people are in ketosis because you're confirming that, you're following them for a year, and you've got 100 of them, and as we said, they've got high LDL because they're on this diet, but everything else pretty much looks good. They're lean, they're metabolically healthy, they're not inflamed. What were the key things that you measured in terms of outcomes here, and what were some of the basic results you found?
Yeah, so the primary measurement was change in plaque volume over time. So we looked at did they build up a lot of atherosclerosis over the course of a year? And we first compared them to a control group, which was a population-based group of patients from what's called the Miami Heart Study, who also had quantitative plaque assessment at baseline. And they had very similar plaque components at baseline. So at least going into the trial, they didn't have a lot of plaque. They even though they were on keto for on average about 4 years, some of them for as long as 8 years, they didn't have a lot of plaque in their arteries when we first did the intake. And over the course of a year, there was some plaque progression. Now, we saw an average plaque progression that was probably in range with other studies. So it didn't look like they were fueled to have very rapid plaque progression. We saw kind of a more of a modest plaque progression. And when we looked at the relationship of what caused the plaque to go up, it was not the LDL or the ApoB. It was the underlying plaque. So if they had a lot of plaque at baseline, they got more plaque over time, which might be somewhat of an obvious finding, but I think the interesting finding here was that there was no relationship between the height or the peak of the LDL cholesterol that they achieved and their rates of plaque progression. So some people with crazy high LDLs had no plaque progression, and other people with more moderate LDL elevations did have plaque progression.
And so that would be surprising to a lot of people, right? So we sort of said before that one school of thought was basically that, okay, if you raise your LDL and your ApoB goes up, these things will be part of the causal chain that leads to plaque buildup, that leads to heart disease. So the expectation from that viewpoint would have been, if your LDL is high, your ApoB is high, those people specifically should see the most plaque buildup, but you're saying you did not see that relationship.
Exactly,
Mhm.
exactly. Yeah. And therefore, we always had this at least hypothesis that it wouldn't just be purely driven by LDL cholesterol in a metabolically healthy person. So in a person whose underlying health is good, LDL by itself may not be the only thing that were the primary driver of whether or not they get more atherosclerosis.
Mhm. Talk a little bit more about the patient population, how you recruited them. So obviously they're lean and metabolically healthy because you specifically selected for that. They're also on a ketogenic diet. Obviously, I'm imagining that is there any sense here that these people are A, they're very health minded people. B, they're interested in sort of trying new things and new diets. That's why they're on the ketogenic diet. Are they, what are all the ways that they're deviating from, say, the average American? And are there any potential confounds here with respect to who is actually in the study?
Yeah, I mean, so we had a pretty good variety of people from across the United States. The study paid for them to fly in to get their scans. So I think that it was a fairly diverse population, both for age and pretty good uniform across, sex and age distributions, that we saw a pretty wide variety of patients. Again, it was only 100 people, so we can only subgroup it so much. But I do think that it was a fairly good representation of these so-called lean mass hyper-responders that we did enroll.
And talk a little bit about the age distribution. Are these mostly middle-aged people? What did the age distribution look like?
Yeah, so we did have a nice spread in age. I think I'll have to look back. I think the youngest person in the trial was in their 30s, and the spread in the age was actually quite nice. The mean age was 55, but we did have a pretty good range of ages in the trial. So it was middle aged, but there was a spread of younger and older people also enrolled in the study. We didn't just limit it to people in their 50s, for example.
hmm And so, based on just your experience as a cardiologist and what's out there in the literature and has been out there for a long time, if you were to just take random people from the US population, say, totally random sample of people, and you were to follow them for 1 year, regardless of if they were healthy, unhealthy, ketogenic diet, any, just random people, would you tend on average to see a little bit of plaque buildup year by year simply as a matter of age?
For sure, for sure. Yeah, age is a major driver because whatever your risk factors are, they've been affecting your arteries for yet another year and another year and another year. So the older you are, the more plaque people tend to have. But again, we see 80-year-olds with clean coronaries, and I see 30-year-olds that look quite ill.
hmm
So it's not always a very linear response.
And what are are there clear cut things that explain the two ends of that spectrum there? When you see someone who's pretty young and they've got really bad looking arteries when you do these scans, what are the things that associate with that? And then, the opposite, someone who goes to advanced age and still has really clear vasculature.
Yeah, I mean, I think that's always been a very interesting question, and why some people get spared. And obviously, there are some things we still don't understand. For example, genetics. We don't even know the genes
hmm
that drive atherosclerosis yet. We've been looking for a long time and can't find like the one seminal gene. It's probably a host of multiple genes, but some people just might have better genetic makeup and be more immune to atherosclerosis or immune to high LDL cholesterol, whereas other people may be very susceptible to it. And that's why we really have to look into the arteries and to do those heart scans to say, are you being affected by these values? And if the answer is yes, we have good treatments to then delve into.
hmm hmm And so for you, what would you say sort of the major takeaway of the study is? And then, people have been talking about the study quite a bit. It's starting to get a lot of attention. So what's the main takeaway and conclusion for you personally? And then what are some of the best fair-minded criticisms or questions that you've seen come up around how the study was done?
Yeah, so, I mean, as far as, I mean, obviously, it would have been nice to have a control group where we had a group of people who were matched exactly, who underwent the same two scans, but were not ketotic, right? Who were not in this not on a ketogenic diet. But this was funded by a foundation. So this was, kind of group funding. And we just did not have resources to do a larger, scale trial. We are going longer. We are going to follow these people out further. This was the first year, and we are going to hopefully get these patients back in to get a third scan over some interim time period so we can see what the long-term changes are on these plaque results. But I do think it was, an interesting finding that this really high LDL, some people would say, even call it a scary high LDL, did not directly impact the coronary arteries
hmm
directly. It wasn't based on that elevation in LDL that was the reason or the direct relationship with having more plaque at the end of the trial.
Yeah. And so you guys are doing longer term studies. I would imagine that there's probably quite a few people out there of the mindset that, okay, you only that this is great, but you only follow them for a year. If you do 5 years, 10 years, and so forth, then their LDL will become predictive of plaque buildup. And is that what some people are saying? And is that what you guys are basically going to look at eventually?
Yeah, yeah, and our goal was always to try to come up with more funding and do a further longer term follow up at 5 years to see what the 5 year changes are over time. And we are, I'm pretty confident bringing back these patients in the short run, a shorter run than 5 years to see a third point in time to see what's been going on as this gets further out.
Mm-hmm. So, stepping back for a second. So I am 37. I'm approaching 38. I've never had my arteries looked at. I've never had a plaque scan or anything like that. Is that something that you would generally recommend? So I'm lean, I'm metabolically healthy, and all that stuff. Is that something I should start thinking about at my age slash, at what age would you start recommending people get regular scans to look at the potential plaque buildup in their vessels?
Yeah, I mean, generally we talk about men roughly age 40 and older. That's usually the age of atherosclerosis. Women 45 to 50, they tend to get heart disease a little bit later. Maybe around the time of menopause, women should start thinking more about their heart and, obviously focus on that as their primary cause of harm. A lot of women focus on breast cancer, but after menopause, 10 to 1 they will die of heart disease and not breast cancer, 10 to 1.
Mm-hmm.
So I think, at menopause, I try to convince women to, around that time, to get their heart scan. Men in their 40s or early 40s, usually, depending on risk factors and how healthy they are. They can wait a little while, they can get it a little bit earlier, but roughly 40 is a good age for men.
Mm-hmm. And you said that's an easy scan to do. Is that something that people can or should proactively ask their physicians about?
Yeah, yeah, it should be widely available now in the US, and some insurances cover it. If not, it's usually like a $99 or $100 test. It's usually not an expensive medical test to get the heart scan done.
Okay, so basically after roughly the age 40, there's no reason not to do it. It's not prohibitive. Your doctor shouldn't say no. There's no reason not to do it, and it's only about $100.
Correct.
Okay. So in your how did you sort of get into this group to do this study? What was making you think about the ketogenic diet? And, is this something that you started getting interested in recently, or have you had these ideas for a while? Like how did you get in as a cardiologist? How did you move into the realm of looking at the ketogenic diet, which in some ways it's sort of it's a new and, not exactly mainstream thing to look at within cardiology.
Yeah, no, I mean, I was approached by this foundation and asked if I would do a study if in this population, and we helped design the study. And I was, I was really agnostic on what it would show. I'm not a ketogenic diet expert, but I read the literature, and it seemed like there was a fair chance that that these lean mass hyperresponders, because they're overwhelmingly so healthy otherwise, that they may not have a lot of heart disease. And conversely, this high LDL may be driving cholesterol into the arteries and causing problems. So I thought it'd be a good question to answer. So I thought it was appropriate to answer it whenever we have that equivocal, information. It's healthy to do a research study and try to answer some of those questions. And I think we answered at least a little bit of the questions that are being raised, and there's a lot more to be done.
Mm-hmm, mm-hmm. Okay, so you didn't really have strong expectations as to what the result would be, but you were surprised to some extent by what was found.
Yeah, I mean, I have to say, even at the baseline scans, when I was taking these patients with LDLs of 400 and 500 milligrams per deciliter and doing scans on them and seeing clean coronaries, I was quite surprised.
Hmm.
To be honest, I thought that they would have much more advanced heart disease even over the 4 to 5 years that they've been on the keto diet. And again, these patients were in their 50s, so it wasn't like they were young kids that we were studying. We were studying middle-aged people who should have some plaque. And then you would think if you fed that plaque aggressively, that they would have a lot of plaque, but clearly they did not,
Yeah, yeah.
at least at our baseline study.
Yeah. Okay. So these were people, so many of them were middle aged, as we said. Many of that. So even though this is a 1 year study for what you guys did in this particular paper, most or many of these people had already been on a ketogenic diet for several years.
Yeah, the average I think was about 4.5 years coming into the study.
And what were some, like, do you guys know, like, what were some of the reasons that these people got on a ketogenic diet to begin with? Were many of them overweight and obese and then became lean, or were most of them already healthy the whole time?
I think my understanding is, and I didn't interview all of them, but a lot of these people were healthy people who turned to the keto diet for maintenance of their health.
Mm-hmm.
There were some that had other medical problems, but if they had diabetes, if they had other medical problems, they were not allowed in the trial. We were looking for lean, healthy people who were having this hyper response because those other people, typically the LDL actually goes down. If you read about the ketogenic diet, when you lose weight, your blood sugar gets better, your LDL cholesterol should come down to some degree. It's
Hmm.
actually a way to control your cholesterol. So we're talking about these outliers that have this remarkable response, this almost paradoxical response to their diet, where their LDL cholesterol goes up really high.
Yeah, so it really is a lean mass hyperresponder phenotype specific. Like it truly is these lean metabolically healthy people that see these high LDL levels on a ketogenic diet. What you're saying is actually people who don't fit the mold there, people who are overweight or otherwise unhealthy, they will often actually see the opposite. Their LDLs may actually come down on a ketogenic diet.
In most people, it comes down.
Hmm.
So again, these are the less common denominator of these lean mass hyperresponders is the less common response to this
Hmm.
diet.
Hmm. So given your background as a cardiologist and a variety of the things that we've mentioned already, I want to ask you a little bit more about statins because this is, I believe, statins are the most widely prescribed drug out there as a category. How how effective are they? Do you think they're overprescribed? And what are your general thoughts there from a cardiology perspective?
Well, I mean, if you look at people who've already had a heart attack, they all need to be on a statin. And if they're not on a statin, then it's being underprescribed. Because once you've had enough plaque in the arteries to cause a heart attack or a stroke, you have too much plaque and we need to reduce it. And statins are the way to do that. For the vast majority of people who are being treated just because their LDL value is high, some of them are being overtreated and it's not necessary. But overall, we believe that statins are still underused based on the prevalence of heart disease and high risk people in our population. But it may not be, it may just be the wrong people are being treated. And that's where I'm hoping the heart scans, the coronary calcium scans that we discussed, can help direct those people who need treatment. They have a positive scan, they have plaque in their arteries, they need to be treated, and find those patients who have no plaque, scores of zero. They have
Mm-hmm.
no detectable plaque and don't need to be treated. And we can better delineate who needs therapy.
Yeah, and so just to reiterate, what you've said before, you need to know what that plaque buildup looks like. And so you need one of those scans. Just knowing your LDL number and your cholesterol biomarkers is not enough because if you have clean arteries and your LDL is quote unquote high, it's a very different situation than if you've already had a heart attack or you've already got a lot of plaque buildup. So there's no reason, certainly past the age of 40, it sounds like, not to get one of these scans at least every few years, I would imagine, right?
Yeah, I think, yeah. And if it's completely zero, we say you can wait up to 5 years. If it's abnormal, you might want to repeat it a little bit earlier to see if it's getting worse.
Yeah, yeah, yeah. Um, okay, so remind us again, your what are the next steps with this study and this line of research? It sounds like, are you following the exact same people for 5 years, or are you doing other types of experiments as well?
No, no, same people. Yeah, we're going to try to maintain these 100 participants. We've already been following them. The first scans were done a few years ago, so we're already a few years in from their baseline scan, and we're going to, I think, bring them back in shorter order to address any questions about going untreated or putting anybody at question. So we're going to try to get them in, I think, sooner than 5 years, and then hopefully also again at a full 5 year follow up at least
Hmm.
to have longer term follow up and look at the influence on the coronaries.
hmm So a couple final questions here because I know we don't have much time. Um, let's imagine you're talking to a couple different types of people. So the first type will be what we might just call like a typical middle-aged American. So let's say that they have never had a heart attack or anything like that, but they're not exactly metabolically healthy. Maybe they're pre-diabetic or diabetic. Maybe they've got high triglyceride levels. Maybe they've got some plaque buildup. They're certainly not in the pinnacle of health, but they haven't had a heart attack or anything like that either. What should they be thinking about? So let's say they need to lose weight and get somewhat more metabolically healthy, but their LDL's higher than average. And I'll let you maybe steer us in terms of the numbers we should be looking at here. What should they be thinking about in terms of whether or not to be thinking about statins, whether or not to be thinking about changing their diet, potentially trying something like the ketogenic diet? How would you start to steer someone to think about their overall health when they look like that kind of typical middle-aged American?
Yeah, I mean, I think, if they want to lose weight, obviously we have some great weight loss drugs now, but if they want to lose weight through diet, keto is probably the best diet for weight loss. It's going to be the quickest, and probably the most expeditious way to lose weight from a dietary standpoint. The Mediterranean diet is great for longevity, but doesn't come with much weight loss. And a lot of the other diets have just failed over time. So I think if they want to lose weight, I'm not against the keto diet. I track their LDL. If they have that hyper response, they have to get a scan. They have to see if they have coronary artery disease. And if they have underlying disease, then I'm a little bit more anxious about not treating them with something, whether that's a statin, whether that's aspirin, whether that's other therapies, to make sure that we're treating the underlying risk that may or may not be exacerbated by this diet.
Mm-hmm. How do you think about so on a patient by patient basis, how do you personally with your patients think about how high is too high when it comes to things like LDL, given what that patient's sort of specific characteristics are, and then thinking about like what the guidelines actually say. So to say that another way, you know are there cases where a patient has an LDL that technically is higher than what the guidelines say it should be, but you don't think it's inappropriately high?
Yeah, so I think that the guidelines talk about LDLs of 190 milligrams per deciliter as being too high and warranting therapy. I think that's overtly incorrect if they have no plaque in their coronaries. And we
Mm-hmm.
have great data over lifetimes of patients. I'm not talking about now a 1 year trial with keto. I'm talking about a lifetime of treatment where patients are treated with or have high LDL cholesterol. They're never treated, and they never develop heart disease or plaque in their coronary arteries. So I say if their LDL is elevated or their cardiovascular risk is elevated from other factors, age, blood pressure, diet, diabetes, history of smoking, family history, that they undergo a heart scan. And if the heart scan is zero, they don't need to be treated for the next 5 years for their cholesterol. It's okay because it's not causing plaque.
Mm-hmm.
And if their heart scan is abnormal, then they need to think about treatment. And the higher the heart scan, the more plaque we find, the more aggressive we get with treatments.
Mm-hmm. And so remind us, you mentioned this briefly towards the beginning, but is when you start to have some plaque buildup, is this something you're stuck with forever, or is that at least partially reversible?
So it definitely can be halted, and in some cases can be the soft plaque, the non-calcified plaque can definitely be reversed for sure. We definitely have seen regression of plaque. What we haven't seen is regression of the calcium, the calcified plaque. That seems to be more of a scar tissue or a permanent finding in the arteries.
Well, first of all, I want to thank you for your time, Dr. Budoff. He's a busy guy, everyone, and I got him here for an hour. So thank you very much for doing that. This is a really exciting study. Anything you want to reiterate about the study, or any final thoughts you want to leave people with in terms of just heart health and thinking about how to manage that and track that over a lifetime?
Yeah, I mean, I just we're not good at looking at the outside of a person and understanding what's going on inside. And you'd be surprised. I see these people who they're excellent athletes, they're in great shape, they've eaten well their whole life, and their arteries are clogged up because of genetics or because of bad luck or whatever that is. And conversely, I have people who probably shouldn't be alive. They've done everything wrong. They're overweight. They never exercise, and their arteries are relatively clear. So I think, a simple test to say, are you in that group or not, is, like we talk about mammograms and, do you have breast cancer or not? We can't just look at you and say, oh, you look healthy, you probably don't have breast cancer, or you look sick, you might have it. We do mammography. This is the mammogram of the heart. We're going to look into the coronary arteries. We're going to say you do have disease or you don't have disease. And if you don't have disease, you can work on those risk factors and be healthier, of course, but there's nothing urgent to start a statin or start other treatments. If we find a lot of plaque, despite your good lifestyle, it's time to think about treatments. And there's other treatments beyond statins. I know not everybody likes to take statins. They've heard negative things about them. I think some of those are overblown. But for my patients who are reluctant or refuse to take a statin, we do have a good number of alternatives now to help manage their risk and give them a longer lifetime by treating their underlying risk factors. And we just need to identify who to treat. And that's where I think the heart scan becomes critical. And we're going to learn more about the keto diet. And we're going to learn more about different therapies like the injectables, the people that are using the GLP-1s to inject themselves to lose weight. Are those good for the arteries or not? We don't know yet, and we're learning. So we're going to get more and more information about a lot of different treatments by watching what happens to an individual over time under the influence of drug X or diet Y or lifestyle Z.
Mm-hmm. So it sounds like one thing I'm taking away from everything you've said is, despite everything we've learned, despite all of the studies and all of the years that have gone by, we should still be humble because there's a lot of mystery here. You still get plenty of people that do everything by the book. They exercise, they eat right, but their arteries are clogged. And then you also get the opposite, people who've spent a lifetime doing all the unhealthy stuff, and for whatever reason, we can't explain it, their arteries sometimes look clean.
That's true. That is absolutely correct.
All right. Well, Dr. Matthew Budoff, thank you very much for your time, and I look forward to seeing what the next 5-year result looks like.
It's been a pleasure talking with you, and I hope this was helpful for your listeners as well.
Visit mindandmatter.substack.com to find all of my content. This episode is supported in part by Athletic Greens. Their main product, AG1, is a comprehensive and convenient daily nutrition product containing 75 vitamins, minerals, and whole food sourced ingredients with less than 1 gram of sugar per serving, no nasty chemicals or artificial anything. It's gluten and dairy free and compatible with paleo, vegan, vegetarian, and ketogenic diets. AG1 is a quick and convenient way to supplement your diet to help ensure your body is getting the nutrients it needs. It comes in powder form, and you can mix it in water and drink it, or you can put it into a smoothie or a shake or something like that. I mix it into water and drink it, and it's super convenient. If you go to athleticgreens.com/mindandmatter, Athletic Greens will give you a free 1-year supply of vitamin D and 5 free travel packs with your first purchase. Their vitamin D product comes in tincture form, so you just take 1 drop each day. A large fraction of the population is actually vitamin D deficient, especially in winter months when we get less sun exposure. And vitamin D is super important for the proper function of the immune system and for a variety of other things. So visit athleticgreens.com/mindandmatter or click the link in the episode description. You'll get a free 1-year supply of vitamin D with your first purchase.